subscribe and you apply now for the Medicare, you will lose out on your fee-for And that's approximately like $2,000 or more. So I could recommend that you don't start until next year, 2012, where you get the cover.
So in the front and then in the back, yeah.
Is QRI an ongoing process, though? Because you said
Yes.
it would cannibalize the
Yeah.
meaningful use.
Well, I think what we think about the payments is that the feds are going to ultimately issue guidance about how those two programs come together over time. So that's what we think is going to happen with PQRI. We're waiting for the federal guidance on that. I don't have a time frame for that. And then the back, yeah.
If I registered this year but I didn't put a 3-month period, can I just defray it till next year?
Yeah, I believe my understanding is that the registration that you start will roll over. You might need to revisit that again in 2012. I believe my recollection, and I want to check this with Dianne, yeah, as long as you didn't specify the time frame on the initial registration, you would just need to go in 2012 and update any information and then complete the attestation in that year. I think just the thing I wanted to point out, I think that the calendar here, again, this is Medicare, we're going to move on to Medicaid. I think the thing that's important to note is if you want to maximize your incentive payments, entering in the program this year or next year is the way to do that. The bump, if you enter in 2013, is $5,000. You know, in the big picture, that's not necessarily substantial. So you definitely want to think about that. What we do see, however, is that payments did decrease. So the Medicare program is a carrot and stick program. This is different from the Medicaid program. So what you see is that any physician, ambulatory physician who's an eligible provider who doesn't enter into the program by 2015 will start to be subject in 2015 to a 1% payment cut. And this will start to accelerate over time. And I think it's important to think about. I absolutely have had physicians say to me, I'm planning to retire in 2016 and 2017. I don't really want to do this. I don't want to implement an EHR at sort of the end of my practice life. And and I certainly understand that decision making, but if you're going to be staying in practice, this is certainly something you want to consider, not just in light of the incentive payments, but in light of the payment cuts that come after. These payment cuts are in statute, they're not in regulation. And the only reason I point that out is because it takes an act of Congress to change the statute and to change the payment cuts. This is not an action by the U.S. Department of Health and Human Services to say, or CMS to say, we don't want to do the payment cut. Congress would actually have to authorize that. So let's talk briefly about the Medicaid program, and I need to accelerate my talking here. So the Medicaid program is a little bit different. Again, you need to have an adult patient mix that is at least 30% Medicare beneficiaries. In a pediatric practice, it would only be 20% of the pediatric population. The total incentive payment, again, here is higher, is $63,000. For the pediatricians that are qualifying at the lower rate of 20%, it is a lower incentive payment at $42,000. And the program works a little bit differently. There's a loaded upfront payment where you're actually just attesting that you've implemented the EHR. In the Medicaid program, you are not attesting that you've met meaningful use in year one. You're saying, I have an EHR, it's live, and they're trying to get you over the hump. And then in the subsequent years, you need to meet all of the clinical quality standards and other standards associated with meaningful use. So in a certain way, the Medicaid program is, I think, a little more conducive for moving physicians and physician practices and health centers up and on an EHR and towards meaningful use. If you're eligible for this, I certainly encourage you to think about this program. I would note, I did specify this before, you have to enter into the Medicaid program by 2016, and there is absolutely no rate cut or payment penalty in the Medicaid program. So the rate cut only occurs on the Medicare side. But it's certainly, if you go, so anyways, I won't go over it. I won't go over it. I think that we have covered a lot of this. I guess just one One other quick thing, here's a comparison chart. You've got it in the slides. One thing I want to note is under Medicare, once you start the program, you need to stay in the program and you need to achieve meaningful use in contiguous years. I don't necessarily feel like there's been adequate guidance from CMS about how it will be handled if people need to take a pause. And I think that will be further refined with decision making. And then under Medicaid, you can still skip years and receive a maximum benefit just because that program trails out over a longer period of time. Yes.
Maybe I misunderstood, but I thought you said that in Medicare you do not need to meet meaningful use in year one.
Medicaid.
Medicaid.
Medicaid. In the Medicaid program.
I thought you said that the first 3 months you just have to establish use, but you don't have to establish meaningful use.
No. In the Medicare program, that first 90-day period, you are being fully measured on all of the clinical quality and core measure sets that we're talking about. And you absolutely have to hit the thresholds to do that. And we'll show what those quality measures are, and we'll show an example of how that works a little bit later on in the talk. Yeah.
How will that auditing go on? My understanding is to apply for the funds, you have to submit an application of some sort proving the meaningful use, let's say the first 90 days. Going to the next year, I assume there'll be another application process. But then how will they audit you in between those to know that you are or not, etc.?
Yeah, I think that's a great question. So the interesting thing, and we talked a little bit about this last night, so the bond support staff will smile at this. So while all of the work in the healthcare provider community is going on to generate clinical quality measures for meaningful use in year one and to report on them in your first 90-day period, the great thing, or the thing that's completely ironic, is that CMS is actually not ready to take your reporting electronically on those measures. So when you go through to a test in year one, you're going to be taking the data from your EHR and the dashboards that your EHR vendor has, and you're going to be printing that out. And you're going to be keying the numerators and the denominators into the CMS website, into the EHR attestation website in year one. In year two, all the EHR vendors are working towards this right now and putting these specifications in place. There will be the ability to electronically transmit the measure by 2012 when CMS is ready to receive it. And all of the certified EHR vendors are starting to work with CMS and will be testing with CMS the ability to transmit that information. So what will happen from an audit perspective is CMS is going to be checking in subsequent years that they're actually receiving the information. And they're also saying that they're certainly going to do spot audits of the program out in the community to actually make sure that folks are, everything that they attested to is actually true. But we all know with the number of providers in this country, this is going to be a very small sampling methodology. But certainly we do expect that the Office of the Inspector General is going to be doing some spot audits on the documentation for meaningful use with CMS itself and in the provider practices. Okay. So this is a very high-level summary. What they're looking for in stage one meaningful use is to meet certain objectives and measures, and we'll talk about those. And 80% of the patients must have their records in the certified EHR technology is what they're looking for. The eligible providers need to report on 20 of the 25 meaningful use objectives. I know here we're not talking about it at all in the context of this, but the hospitals have an incredibly similar program. There are differences, but the hospitals also have to report on issues as well to get their separate inpatient incentive. And again, we've talked a lot about the reporting period. This is Medicare, so 90 days for the first year and 1 full year subsequently. And here is the list of objectives. So this is the core set of objectives. You need to be able to address all of this in your attestation to CMS. It's interesting, there are less on this and more on the other stuff, but there are exceptions in places to opt out. So e-prescribing, so chiropractors are basically allowed in the attestation to say, I don't prescribe, I don't e-prescribe, and they can opt out. So there is an ability to opt out of measures that don't apply to you. We do think that CMS is going to check those opt-outs and audit them. to make sure that they've been appropriately selected. But this gives you a sense of the core objectives. And it's quite a list. And then here are the menu set objectives. And Diane, I should have this here. You have to choose 5, right? You have to choose.
One has to be public health.
Yeah, choose 5, and 1 has to be a public health item. And here, so in New York State, we're pushing most folks to show their ability to submit electronic data to the New York State Immunization Registry, which is the easiest way to satisfy that. You actually just have to test that in year 1, because New York State is not really well prepared right now to take the electronic syndromic surveillance information, so we're pushing people towards this. And then in addition to the immunization, you need to select an additional 4 from this list. I mean, we could spend hours on registration attestation itself. I'm giving you 1 slide and pointing you towards resources. As someone in the audience noticed, you have to register via the EHR Incentive Program website. I give you the URL a little bit later. You need to be enrolled as a provider in fee-for-service Medicare, Medicaid, and to have a national provider identifier number. And all of eligible providers must be enrolled in PICOs. If you or your practice administrator has not yet taken care of this, this is quite important. It can take a little while to accomplish this, so if that has not been done, you want to do it now. My guess is if you're already sort of pre-registered, you've taken care of this, but that's certainly an important thing to do. I would note that New York State Medicaid has not yet stood up the Medicaid attestation website for New York State. They are targeting December 1 to get that up for both the hospitals and the eligible providers. We have every reason to think that they will hit that deadline. So those of you who are looking at Medicaid, there's a little less information about that, but I do expect some of that to be moving shortly. Yes?
Yes, Susan, will you provide some of the slides that are not in your presentation for everybody? There's a couple of questions from the audience,
Absolutely.
like the one slide and this slide.
Yeah, we will.
None of her slides have been in the presentation.
You know why?
We'll
We
email the
did
slides
this
to you.
last night. We did this seminar last night at another one of our facilities, and I asked them if they could go into a little bit more detail for you guys on meaningful use.
Okay.
Because I knew that the questions that you guys were going to have would be a little bit more specific to meaningful use. So unfortunately, I didn't have enough time to put those slides in that she did for us last night. So, but I can get them for you guys.
And I'm almost done with my part of the talk. I wanted to flag something for those of you in the audience who practice on the primary care side. There is a program that the feds are offering to provide support services to primary care providers in small practice settings to help them achieve meaningful use. Basically, every state in the nation has a sort of a statewide rec or regional extension program that's supporting providers with achievement of meaningful use. In New York State, the statewide HIT organization, NICE, or the New York eHealth Collaborative, is supporting that. We're doing outreach and enrollment for them in the Hudson Valley, because it's hard to get to all 5,000 primary care providers in New York State under the program. What the REC program does is it offers support services to providers. It means a group comes in and consults with you on how to achieve meaningful use, how to do the privacy and security audit, how to make sure that you're attesting and sort of moving on. And we'll even actually help with EHR selection if you're at that point. In the Hudson Valley, if you're working with eClinicalWorks, you'd end up being assigned to MedAllies to support that. If you're working with other types of EHRs, if you're working with NextGen, the Massachusetts eHealth Collaborative is supporting NextGen users. iPro, the QIO for New York State is supporting users on other platforms, be it Greenway, be it Allscripts. And if you had interest in the program, you should certainly go through BOM supports and get in touch with me. To be eligible for the program, you need to be a primary care provider. To meet this, it's family practice, pediatrics, internal medicine. You can have a specialty with internal medicine, which actually opens it up quite a bit larger, and OBGYN. There is a practice setting guideline, 10 or fewer providers in the practice. There's an exception for health centers. Here's the Fed's thinking on the program, that large practices and specialty physicians will have an easier time adopting and implementing EHRs, and there was a real concern that small primary care practices would have less in the way of resources financially and time-wise to support that. And this is the Fed's effort to try and do something to address that gap. And we've got 420 primary care providers in the Hudson Valley that are already enrolled in the program and starting to receive services. And then the last thing I'll say, and the folks at Bond Support will get out the slides to you, but this URL is incredibly helpful. I always believe with a federal regulatory program, it's really important to go to the source. The feds have really sought to try to provide a lot of resources in a way that is, that's fine. In a way that I think is quite thoughtful. When you go to this URL, what you want to look is there's a whole nav bar over on this side of the screen that takes you through really detailed items about who's an eligible provider, about attestation, about the timing of incentive payments. There's a lot of information there, and they've actually been trying quite well. There's a good frequently asked questions section where you can go in and type in keywords or look for your questions. So with that, I hand it over to Dianne. There you go.
So this part of the talk is going to go into an actual EHR application to show examples of meeting the measures. So for those of you that are done with the general information with meaningful use, you're welcome to spend the rest of your day doing your regular work. But this